paralanguage. The music of language often considered a form of non-verbal communication. Now, originally we were talking about how we can say so much without ever saying a word, and so that's how we present ourselves. Patients receive signals about your attitude toward them from the pitch, the stress, the tone, the pauses, the speech rate, the volume, the accent, and the quality of the voice. Now, before my husband passed away, I used to hate when he would talk to me like I was his secretary, because he was the vice president of our company, and so that's how he communicated. So he couldn't separate how he communicated at work and how he communicated at home. And so that was always a constant reminder for us, is like, don't talk to me like I'm your secretary. I said, talk to me like I'm your wife today, okay? Don't talk to me like I'm your secretary. Because when he would talk to me like that, then I would automatically just get riled up. And I wasn't listening to what he was saying because he had me already upset. Okay, so how we communicate with our patients, and it's hard for us sometimes, like if we have a bad patient before and then we go to another patient, it's hard for us to start over at the beginning on this patient when we just came from a very difficult patient. So you have to start at 0 every time, so that way they don't get that preconception. So body language it's a big thing, okay? Like if I were let's just think of your instructors, okay? Now, body language, what does Mr. Donahue always say? Always do. He's always doing like this, right? He's always doing like this. What does Mr. Fong do? Okay, yeah, he does this. Okay, that's what he do. That's what he does. Oh, that was good English, wasn't it? That's what he do. Ooh, love the color of the hair. I wonder if I were to do that to mine. So, what do I have? What kind of body language do I have? I go like this a lot. Like, okay, so are y'all listening to me? You know, are you hearing what I say? Because this is how I try to get my point across. Because I want to include all of you. Okay? Now, if I were a male and I had a bald head, let's say Dr. Black. Okay? Because he's bald head. So if I were to always like do this with my hair, well, with my bald head, I know what kind of signal that gives me. What kind of frustrated, okay? Some women will do that. You'll see me sometimes here at the front desk and I'll do this, you know, because whenever, I love for people to brush my hair. I love to go get my hair done because I'm real tender-headed. So whenever I get flustered, that's what I do. Is I pull my hair back so that way I can kind of stimulate my hair. Those are just little signals that you have. Is it standing up now? Huh? Oh, yeah. So we all have our own little body signals. Like I'm sure your husband or your partner or your children, they know exactly when you're fixed to blow up on them. They can tell exactly when you're going to be happy with them. Touch. I'm a touchy person, okay? Now, I can touch for emotional support, and I always touch for emotional support. Always. I'm going to walk up to whoever I see and say, are you okay? You know, that's what I'm going to do. I'm going to look them in the eye and I say, are you okay? You know, I've even stopped people walking down a hallway. If they're crying, I'm going to stop them. Because that's me. Because what's my main strength is empathy. Okay? I can touch for emphasis. Like are you hearing me? Like I do this, I can also touch you and say, do you understand what I'm saying? Like my granddaughter, special needs, I have to touch her. And she hates to be touched. But I'll touch her lightly on the shoulder. Do you hear what Gigi said? To emphasize, to make sure that she understands what I'm saying. Okay? And of course, radiography, you're going to use it for palpation. And we're going to teach you how to palpate. Palpate is how we touch the body to be able to find the symphysis pubis, which is this bone here, which we try not to palpate. We try to go for the iliacs. Okay? Who likes cats in here? Not many. Who likes dogs in here? I have a cat and a dog. The cat never lets me touch him. The dog always does. He demands it. She demands it. Okay, so this is considered palpation. A lot of sonographers technologists will palpate the iliac crest. If you palpate, a little trick, if the patient is left lateral to cube or right lateral to cube, if you palpate and then bring this finger down, that's L5S1. It's just little tricks that you're going to learn in radiography. Okay? Now, I'm going to use my thumbs to be able to figure out where I'm at, but if I want to angle into L5S1, I'm going to do this. Okay? And that way it's going to tell me exactly where I need to angle my tube. You're going to learn all kinds of little tricks once you're out into the field. Okay? You can, you never want to use your palm, but you always want to use your fingertips or your, I usually use my thumb because I use the other fingers to figure out where I'm at. Okay, so here's just the different ways. Now, notice the bottom one right here. We have to actually move the foot on how we want for it to be positioned. Say my patient can't hold that position. I'm going to use an immobilizing device to hold that. Okay? It might be a sponge with a sandbag to keep it from flopping to the side. Okay? All of those are considered palpations. Yes?
So if an individual has their foot crushed under machinery or something, we need to have it x-rayed. How do we go about
I'm not gonna do much with it.
Okay, cool.
I'm gonna leave it as is. I'm gonna use my common sense on what I have to do to get
And
that.
problem solve to get an appropriate
Correct.
picture. Okay, cool.
95% of what you're gonna be doing in the clinic is common sense.
Okay. I figured that would be inappropriate if they have shattered metatarsals.
Yeah, if they had a bad, say my ankle and the foot is a completely different way, I'm not gonna do that. Okay? But I'm gonna maneuver my plate and I'm gonna maneuver my tube to be able to get the imaging that I want. Use your common sense. Okay? Now, what is he palpating in that end image? What do you think he's palpating?
Spine.
He's palpating the spine.
C7.
Because that little bone right here, these bones right here, that's the end of C7 and T1. So we're gonna palpate that to figure out where we need to point the tube at. Or is it tube? Tube. Okay. Now, if my patient has right lower quadrant pain, am I gonna do number one? Absolutely not. Okay? I'm never going to press. Now the doctors will, because that's how we make the diagnosis of appendicitis. It's called rebound. They push, and when they let go, pain. Pain isn't when they push, pain is when they release. That's called rebound, and that's how they make the clinical sign for appendicitis. Okay? If my patient has an ovarian cyst, I'm not gonna do that. Okay? What I'm gonna do is I'm gonna palpate the iliac crest, which is the top of this bone right here, and I'm gonna go down like this, so I know I'm at the level of the ovaries and the appendix. And that's the differences between, you're gonna be learning cross-sectional anatomy. So depending upon where you aim the tube at will determine what we see. Okay? And what are we gonna see first? If I am right lower quadrant, what am I gonna see? Skin, muscle, and then my organs. What's all on the right hand side? My cecum. If I'm a female, I've got ovary. If I've got appendix, because the cecum and the appendix are pretty close together. And I've got the beginning of my ascending colon. And that's the only thing there. If I see something else, that's abnormal.
Are the kidneys higher up towards the back?
The kidneys are higher up in the back. Now, the right kidney is lower than the left kidney. Why?
Because of the stomach.
Nope.
You got more organs
Here's
on
my
that
stomach.
side.
Because the heart.
You have more organs
Nope.
on that
Not
side?
left is the heart.
Huh?
You have more organs on that side?
Yeah, but what organ mainly?
Liver.
Liver.
My liver.
It's the
My
largest.
liver. Okay? Because if I put the imaging crosshairs right here, what am I gonna see? I'm gonna see liver, I'm gonna see gallbladder, and I might see the superior part of the right kidney. Okay? Because as imaging professionals, we have to think in 3D. We have to think of what am I gonna see? If I do this, what am I gonna see behind it? Okay? One of the hardest lessons for us to learn.
Earlier you mentioned something about looking for an ovarian cyst. If they have pain on their lower left quadrant or whatever.
Then I would look on the left side.
But isn't like doing the method that you showed us, like isn't that gonna press against their side? Like,
No,
is that
because
correct?
I'm not pressing, I'm just touching,
Oh, okay.
okay? So that way I know what level I need to go
I see.
for,
Okay.
okay? Now, you're gonna learn different techniques in radiology, but I've used those techniques in sonography,
Okay.
okay? Now, my ovaries are at the same level, okay? But the left ovary is harder to find than the right ovary. Why? Descending colon, sigmoid colon, rectum. I've got more stuff over here. Okay? So it's harder for me to find the left ovary than it is the right ovary because of the anatomy that I'm going to see there. Okay. We always ask for permission. I usually don't ask for permission. I'll say things like, I'm gonna touch your hip, or I'm gonna touch the top of your pelvis. And if they look at me weird, because I'm looking at my patient whenever I'm talking to them. If they look hesitant, I'm not gonna do it. I'm gonna stop. I'm gonna explain the exam a little bit more, and then I will ask for permission. So I have a story about this. I worked with a girl in Arizona. So she comes into my room. It was only a 2-room outpatient center for ultrasound. So she comes into my room and she goes, "You've got to come do this, lady. You've just got to come and do this, lady." She is just irritating me to death. So I went in, I introduced myself, and asked her what kind of problems that she was having, what I needed to do. Come to find out, the girl that was doing the exam did not ask permission to do a transvaginal exam, and she was a nun. She was a virgin.
Oh, poor.
Now, just because the lady was in her 50s doesn't mean that she is sexually active. And that's why, because she was sitting there, she had her rosary beads, and she was sitting there praying out loud while the girl was
Oh.
inside her vagina. And so I asked the other sonographer, I said, go ahead and go outside and I'll be there in just a minute. I apologized. Is there anything that I can do for you? We won't continue the exam unless you feel that it's necessary. It is a better exam because she's already been penetrated, right? Okay, so why not go ahead and finish the exam with the patient's permission, because it is a better exam. Why? Because the ultrasound probe is closer to the ovaries from the vagina than it is from the top. Because I'm not having to go through skin and fat and muscle and all of that. And we finished the exam. She thanked me. She was grateful for me. And I asked her, did you want to write an incident report? I said, because the others, I told her the name. I said, this is her name. If you want to file an incident report, I can go get my manager and we can do that, because she was wrong. She should have asked you if we could do the exam. She goes, no, I don't want to get her in trouble. And I said, you're not going to get her in trouble, but you could be teaching her a lesson. And she still didn't do it. So, that night, going out for drinks, the other girl, she goes, you don't like me very much, do you? And I said, no, I don't. She goes, why? I said, because you're mean to the patients. I said, you don't need to be doing ultrasound. You need to be doing something else. She goes, well, I have been thinking about going back to school to be a lawyer. I said, you shouldn't be a sonographer. Within 2 weeks, she turned in her notice, which was perfect for me. Because I didn't like to work with her. She was too aggressive. She didn't have any empathy. And it's an outpatient facility. They have a choice on if they want to come to our facility or not. Okay? So, like the girl that did the nun, it could have gone to court. Okay? That facility could have been sued. Because, why? She didn't ask permission. So, whether I'm going in the vagina, whether I'm going in the rectum, or whether I'm just touching the iliac crest, it's all the same. You're touching the patient. Professional appearance. Remember the story I told you about the orthopedic surgeon at Texas Children's? You have to pay attention to that kind of stuff. People don't want you to work on them if you do not look professional. And that's their choice. That's their choice. They don't have to let you do them, especially a student. So when you go into the clinical setting, you're going to go, hi, my name is Georgette. I am from the imaging school. Do you mind if I start your exam? Okay. Well, what is that? That's part of my AIDIT. Now, AIDIT, we're going to practice the next class. So start practicing on what you want to say, because I'm going to put you in groups and I'm going to give you scenarios.
So AIDIT in that sense is sort of dealing with like a verbal consent to even the cervix to be
Correct. Mhm. You have to tell, especially men. When a man comes in there, they automatically think they're doctors. Automatically. Okay? And why? I don't know. It's the man thing. Okay, so let me give you a test. Okay, a patient comes into the hospital. The doctor comes in and says, I can't treat this patient. Have you heard this one?
Yeah, go ahead.
Okay, I can't treat this patient. How does it go? Because this is my son. Is it the mother or the father? First off, I can't treat this patient because this is my son.
Mother probably, no.
Huh?
Because like you said, a father with, he's a doctor, so this is probably
Correct.
the mother.
So you automatically think, I felt it because I guessed that it was the father. Okay? That makes me biased because I think I was going through bias education. I automatically thought it was the father, but it wasn't, it was the mother. Okay? Especially patients will think you are a doctor. Okay, so let me tell you a little bit about the hospital. When you go to the hospital, everybody's in a white coat. All doctors just about wear a white coat. If it's a short white coat, those are medical students. If it's a long white coat, they are either residents, meaning they've already finished and they're going through their residency, or faculty. With the shorts, those are medical students. Okay? So, as a technologist, you know, we usually wear, well, whenever I was in school, we didn't have black available. We only had white. They always thought that we were doctors. Even the females. If you walked in with an examination room and you had on a white coat over your uniform, they thought you were a doctor. And just correct them, say, no, I'm not a doctor, but I'm a technologist. Do you need for me to go and get the physician? You know. Why? Because I don't want to embarrass them. Say, no, I'm not a doctor, but would you like for me to go get the physician? And they'll say, oh, no, I just thought you were the doctor.
Ma'am, did you say the long coat were doctors?
The long coats are doctors. And those coats have, the buttons are like little balls of cloth.
They would also have a badge denoting that
They're physicians. But when you're walking down the hallway, you know, the shorts are the residents, the longs are faculty. Okay. I would recommend that you wear a lab coat. Okay? Because it's just another layer of protection. It could either be feces, throw up, blood, just dirt in general, because we do a lot of homeless. So you want to protect yourself. So say I did a patient that had oozing legs. Okay? So afterwards, I'm probably gonna take off my lab coat. Because now I've got the rest of the day to work and I feel funky. Okay? So the only way that I can help myself is to take off that lab coat and be sure that I wash mine all the way up. You know, because that's gonna help me. Sometimes I've even gone and washed my face. Because sometimes like the smell gets in your nose hairs and you can't do anything about it. I know it sounds gross, but you know, go and wash your face. I mean, they've got wash rags within the department. I mean, use them.
Ma'am, how would the lab coats look like for us?
They can either be white or they can be black. Does anybody have on a black one in here? No? It's almost like, they have elastic here at like a warm-up jacket. They have elastic here at the wrist that you could, they're long enough that you could fold them up. Okay. And they're short. They're usually snap. They usually snap.
What do you mean by snap now?
Snaps?
it's
Like
like
window snap.
pressing something together,
Yeah.
so it snaps
Yeah.
whenever.
Oh, I see. Like,
Yeah, they usually have snaps on them.
no zippers.
They don't have buttons, they have
No
snaps.
zippers.
Like what you have on, you can't wear that in the clinic. Okay?
Not even zippers, ma'am.
Oh, no, definitely not zippers, because that's infection control.
Oh, I see.
okay? So stand up.
Oh, I understand the metal,
Okay.
metal
Now,
buttons.
she would not be able to wear this in clinic. It's not official, it's not, it either has to be a lab coat or just her uniform. Okay? Now, you stand up. See her long sleeves? Those are acceptable. So if you know that you get cold, you don't have a lab coat, wear something long underneath it to keep yourself clean. But if I have long sleeves as a sonographer, I'm gonna always put a gown on overwards because this arm is on the patient's body. Okay? Yes?
Quick question, let's say one day we're working in the OR or anything like that, and then we do get blood on our scrubs, like. do we
You're not
just-
gonna have on your scrubs, you're gonna have on OR scrubs.
Okay, you don't.
But you can get blood on your scrubs down in the trauma rooms.
And what happens to the scrubs, like?
Usually if they get dirty, go to your sonographer, your technologist, your supervisor, and they'll give you a code and you can go and get some, scrubs to wear for the rest of the day.
And then these, you wash them at home, or?
And
throw
no,
them
you
away?
bring them back dirty. The uniforms that they give you, you bring them back the next day because they're in a machine. And when you check something out, you have to check something in. You don't have to wash those.
Okay, so you leave yours and then.
Yeah.
Okay.
Yours, you're just gonna put them in a red bag and take them home and wash them home.
I think that's what her question was.
Yeah.
Like you wash your own stuff?
Yeah, you wash your own.
Would there
Then
be,
the blood would come off though, like.
Well, we're gonna show you and teach you some of those things that will help blood come out, okay?
like proper disinfectant for things like that, let's say like you, to double back, like what would be the proper PPE for, let's say if we're dealing with
If I'm doing a
homeless-
blood,
Well, if we're just dealing with a homeless, individual or.
oh, I'm gonna
just
put on a
really-
yellow gown.
It's a full out hazmat suit?
Yeah.
Okay,
It's not really,
like,
yeah,
yeah,
it's waterproof, you stick your arms in it, your front is covered, it's yellow, and it ties in the back. Okay, so anytime I'm gonna do something that I know is going to be kind of funky, I protect myself, and we're gonna show you how to put those gowns on and how to take those gowns off. Ballpoint pen, if you get ballpoint pen on your uniform, hairspray.
What?
Hairspray. Hairspray. Hairspray takes out ballpoint pen.
Well,
Okay?
really?
If I have blood, what am I gonna use? Hydrogen peroxide. Okay? Okay, so always go to clinic and class where you smell good, you smell clean, you don't have any cologne on. And women and men, do not use 15 sheets of Downy. Those,
That's your dry sheet dryer?
yeah, the dryer
Oh.
sheets, okay, the dryer sheets. Cause I've had to counsel one of my students because if she was in this room right here and I walked through there, this room would smell like Downy. And it took me a while to figure out where's that smell coming from. Okay? And it wasn't until she walked into my office as soon as she walked in to the department. And I thought, oh. So I had to counsel her. I said, you know, only use just a cup full of sheets of Downy because it's overpowering. And when you get to clinic, someone's gonna throw up on you. Okay?
so you literally mean counsel as in like the disciplinary action that
Yes.
you've taken, okay,
Yeah. I give a verbal first, but the verbal has to be documented.
right,
Okay? The verbals we usually keep on our desk. We keep on our desk until we have to write you up, and then the verbal goes into your file. Okay? Perfume's the same way. Don't wear perfume. Some women, that's just part of them getting dressed in the morning. They put on their deodorant, they put on their makeup, and then they spray their perfume, or they spray their perfume. Or they spray their perfume and walk through it. Okay. It's gonna make your patient sick. And the only reason I'm telling you this is because I've already been through it. Okay? So, we had a patient one time, and on the requisition, it says no perfume. Well, I didn't wear perfume, but I wore that scented, what was it? It was lemon, some kind of citrus deodorant. I walked in and she immediately said, "You've got on perfume." And I said, "No ma'am, I don't have on perfume." I said, "But if you can smell me, then I'll go and send someone else." No, let's just get this over with." She goes, "But you've got on perfume, I can smell it." And I said, "Well, I have citrus flavored deodorant on." She goes, "I can smell it." Okay. So what did I do? I went to the store and I bought unscented deodorant. So now, if you're working for an orthopedic surgeon in their office and you're taking off cast all day, yeah, you're gonna look like this. Okay? You're gonna look like this. But I would never show up to work like that. That almost looks like bleach got caught into their washing machine. So personal hygiene, it sends a powerful message. Hair, nails, teeth, all of them should be clean. Nails shouldn't be more than 1/4 of an inch over the top of your fingers. Only wear clear nail polish, and it has to be unchipped, because if it's chipped, it's infection control. So you don't wash your hands after work. You go pick up your baby. You put your baby in a car seat. You put your baby on the changing table when you get home. You put your baby in its high chair, and then you start feeding your baby. You picked up MSRA, and notice I never washed my hands. Okay? So what have I done? I have given my baby MSRA. Okay? It's the most powerful virus that we can pick up in the hospital. It's highly contaminated.
Contagious?
Yeah, it's highly contagious, thank you. Okay? And believe me, I know. Because I took MSRA home to my children. Okay, there was an MSRA outbreak at the hospital. So they gave all of the employees a nasal swab and sent nasal swabs home with us so we could swab everybody in our family. Okay? Both of my children got it, but my husband didn't. Okay, so it's very, very easy.
Ma'am, did you say MSRA?
Yeah, MSRA. The only way to cure it is antibiotics. And the strains now are antibiotic resistant. Okay? MSRA can kill you. Okay? So you want to shower every day. Try not to use too strong of a shower gel. Okay? Brush your teeth, use mouthwash, avoid body odors, and don't use strong colognes or perfumes.
Some mouthwashes really have like a strong odor as well.
Some of them do.
So we would have to refrain from using those as well.
Yeah, like me, I have PTSD, and mine has to do with Listerine. When I smell Listerine, I have a panic attack. Okay?
Yeah.
So it's just, it could be something just that simple.
given that you've been in the field for so long and you have an experience with that, what would be a mouthwash that you recommend?
Like Scope,
Okay.
you know,
Any
you
particular
can
color?
use Listerine, that's fine. It's just that my PTSD causes Listerine, causes me to have a panic attack. That smell
Yeah.
throws me into a panic
Yeah.
attack. Okay? So any of them are gonna be okay. Okay? Like right now, what I'm using for a mouthwash is what the dentist gave me because of gum disease. It's not so bad. Okay? So be careful with this. You might want to, if you have greens for lunch, just go to the bathroom and swish out your mouth. You know, you can have a toothbrush. You can, you're welcome to use your toothbrush in the bathroom, but I would not use the public restroom. I would use the restroom for my department. Okay? But I tell you right now, anybody, don't sit on the toilet unless you put that paper down. Okay? Even if it's employee. Because you can get crabs from the toilet seat. Okay? You don't want to sit on somebody's pee-pee that's already been done. Like whenever I walk into the bathroom, I look at the toilet seat to see if it's clean or not. And if it looks wet, I'll go to the next one. If it still doesn't look good and I gotta go, I'm gonna clean that toilet seat with at least a paper towel or with a little bit of soap before I sit down. And then I'm gonna wash my hands really good because they don't supply gloves in the bathroom. Okay. Smoking. Try not to smoke on your way to work because it sticks to your clothes. I'm a smoker. Miss Vance just found out last week that I'm a smoker. She goes, I didn't know you smoked. And I said, yeah, I smoke a cigarette on the way home from work sometimes. She goes, I didn't know that. I said, sometimes I need that cigarette on my way home. Okay? I never come to work with a cigarette. If you smoke marijuana, yeah, they're gonna do a drug test on you because you're gonna come to work and you're gonna smell like marijuana. And I've worked with people that did that. Okay? So be very careful. So, you dress for success. When you are dressed and looking good, your posture is different. You carry yourself different. You carry yourself with confidence. Okay? Carry yourself with confidence. Visual contact, oh, I love that. Okay, so when you're talking to someone, I have the tendency to talk to them, and I do this with my eyebrows when I'm listening. To me, that's just what I do. I raise my eyebrows. I didn't even know that until it was brought to my attention. Now, have I tried to fix it? Yeah, but I catch myself doing it all the time. I can't catch myself all the time. Okay? So when I'm looking and I'm talking to you, I use my eyebrows to let you know that I'm listening to you. Isn't that crazy? Kind of like this. Okay, that's kind of creepy. Okay. Understanding various types of patients. So this patient is intubated, meaning that he cannot breathe on his own. Okay, that's scary for someone that has never seen this before. Okay? Okay, so seriously ill or traumatized patients, they act differently because of the pain, the stress, or the anxiety. Okay, when you have a patient and their pain level is at a 10, they cannot sit still. Okay? They cannot sit still. It's almost like a woman in labor. A woman in labor cannot take a step. But if I have Braxton Hicks, I can walk. Braxton Hicks is like a false labor. So when your level is at a 10, the patient cannot sit still. They have to constantly be moving, okay? Which makes it hard for you to be able to position your patients, okay? Now, whenever I have my patients and I'm talking to them, I'm able to see, do they understand me or not? I might have to use a simpler language, a simpler instruction, okay? Because I need to find out, are they coherent and do they understand me? If they don't understand me, protect yourself and say, patient unable to cooperate on your requisition
When you're documenting?
when you're documenting, okay? You have, with those patients, you have to work very quickly and very efficiently, okay? Some of them you have to continuously talk to. There can't be a break. You have to continuously talk to them. Like, taking a deep breath, hold it, hold it, hold it, hold it. Now breathe. Now let's go ahead and put you up onto your left side. Now, what we're gonna do now is I'm gonna reposition this tube and we're gonna take one more image and then you're gonna be finished. I'm continuously talking to them. Okay? I'm not giving them the chance to respond back. Because you always have those talkers. You have to overtalk them. To get your work done, you have to overtalk them. Because what happens, some people, when they get nervous, they overtalk. Okay? They overtalk. And now, remember what I told you, that patients will do anything you tell them to do? Okay, say you have a patient on the table, they're a talker, they're very, very nervous, they keep talking, you're having a hard time being able to overtalk them. Give them instructions, they have really, really bad breath. I need for you to turn your head to the left. Okay? Because they're gonna turn their head to the left. That's gonna help you breathe a little bit better. Okay, because they're gonna do exactly what you tell them to do. Okay? Now, when you're doing your exams also, you have to pay attention to your patient. If your patient is doing this, what's fixing to happen? You're fixing to get thrown up on. Okay? Turn them to the left. Don't turn them towards the right, because why? Because you're on the patient's right. Turn the patient to the left. Okay? So you have to listen for that. Not only are you listening for your patient, if you work in a department where there's lots of rooms, you're also listening for the waiting room. Non-English speaking. Do not raise your voice. They're not deaf. They hear you, they just don't understand. But it can be very frustrating. But we're a multicultural, multi-diverse classroom. So if someone speaks Spanish and you know that you have a Spanish-speaking student in the next room, ask them to interpret. Or we have interpreters, okay? A lot of times you can use hand signals, you can, they all understand yes or no or stop. But in X-ray, you have to find out when their last period is, right? On all your patients, you have to ask, when was your last cycle? If you don't understand Spanish, I always kept a little, you know how Hallmark gives out those free calendars every year? I would have it in my pocket and say, Tampax, and I would point towards the days. Because I didn't know how to ask them when, because they all understand either Tampax or Kotex. Okay, they understand that. And then I would point towards the days, and that would let me know, like they, and I'd say, they would point towards a day, and I said, was that day 1? Because they all understand 1, usually, and they all understand stop, no, you know, those easy commitments. Okay, so you can go and get a coworker, you can use a patient, but we prefer a translator.
I have a question. So I thought all hospitals had like a monitor where, like a video call where they have like a translator.
Yeah,
talk
now
to
they
them?
do.
Okay.
Yeah.
Do
Now
we
they
have
do.
access to them?
Used
or-
to, yes. Used to, we only had a phone line, but now I think they have a video call,
Yeah.
okay? We wanna use the patient last, okay? But if I have a patient that's irritable and I need for that patient to calm down, her daughter's with her, I'm gonna go and get her daughter, because that daughter is going to be able to calm her down versus a translator. But if I was fixing to do an invasive procedure, I wouldn't use the daughter, I would go to a translator. Does that make sense? Use your common sense.
So, are we allowed to bring family members into the X-ray room?
Sometimes yes. Okay, you'll have to ask your facility.
Okay.
I know in sonography, we can have 1 person.
I got yelled at this weekend because I brought in a family member,
Yeah,
and the X-ray technician was like, "You absolutely cannot bring them,
yeah.
even if."
Because it's ionizing radiation.
Yeah.
If they're uncomfortable, I'll leave them right outside the room. Either I'll leave them in the waiting room or I'll leave them right outside the room. I'll let them come into the room while I'm explaining the exam, but then I have them come out because of the ionizing radiation. But you'll have to find out from your facility. Like Strawberry Clinic might allow someone to come in for a Casa de Amigos, won't. Okay, every place is different. So now you know, okay, at whatever facility you were at, that you don't bring the patient in,
Yeah.
especially with ionizing radiation. Sign language. Mentally impaired patients, we do a lot of those. Harris Health System has a hospital for mentally handicapped. And then we also, at Ventab, at the NPC building where we have the auditorium, the top floors are for mental wards. These patients always have an aide with them. I can't remember what they're called. Okay? They actually have a license to work with patients that are mentally impaired. Okay? Always allow the family or the caretaker to help you. Okay? Be very patient with them. Substance abusers, no, you're on your own on that one. Okay? Sometimes they can be very, very aggressive. And sometimes they can't stay awake to take instruction, depending upon the drug that they're on. And there's some drugs that they could be on where it's scary. Okay? Go and get help.
Like they're scary or?
You're scary.
Okay.
Okay? You can definitely tell when you don't want to be in a room by yourself. Listen to your inner voice. Listen to your inner voice. If something scares you or you feel uncomfortable, you go get help. Okay? No one's gonna say, no, I'm not gonna help you. They're gonna come and help you. Okay? So, because they're under the influence of either downers or uppers or PCP or acid or whatever, okay? Whatever they're on will determine what type of influence that drug has on them. We have to be very firm in our directions. We never want to force the situation. And what am I gonna write on my requisition?
Patient was not cooperating.
Yep, patient unable to cooperate. Not the patient would not cooperate. Because they're gonna say, well, you should have made them. But if you say the patient could not cooperate, then you're covered. Okay? You might have to bring them back at a later time. If the patient came from the EC and you weren't able to do it, type on there, patient unable to cooperate, send them back to the emergency room. Bring them back later.
But you don't have to specify as to why, because that would sort of violate.
No, cause it's gonna say,
Okay.
it's gonna say on your requisition. Okay. More than likely. Okay.
I just wasn't sure if they, if you were supposed to specify that yourself, or.
No.
Okay, cool.
It's already gonna be specified for you. Okay? And why? Because I wanna put on the proper PPE to do the exam. So the emergency room is gonna kinda give you an idea of what you're dealing with. So I wanna begin by calling the patient's name. You're gonna identify yourself to the patient and you're gonna explain the procedure. If you go out there and you call a name, Shepherd, and no one answers, I'm gonna go to each person and check their armbands. If it's an outpatient, I'm gonna go and ask them their name. Because what happens? Patient didn't answer, they go to the bottom of the stack. And your patient might have been asleep and didn't hear their name. Okay? So do everything that you have in your power to get that patient's exam done. So cognizant, meaning they're all in there, and incoherent patients will demonstrate increased cooperation if they hear a kind voice and explanation before being touched. Even if not heard, a caring tone and a gentle touch often has a positive effect on the patient and the family. Because the family is watching everything that we do to their loved one. A caretaker is watching everything that we do to a loved one or someone under their care. Okay? So whether it's a patient or whether it's a caregiver, excuse me, a caregiver, I'm gonna keep them informed. Like whenever I leave the room, I'm gonna tell the patient, I'm gonna go and get my films checked, I'm gonna leave about 5 minutes. Would you like for me to go and get your caretaker? Okay? A lot of times they'll say, no, I'm just gonna lay here and sleep. Or yes. Okay, I'm gonna bring the caretaker in because I want my patient to be taken care of. And say, and I'm gonna tell the caretaker, I'm gonna go and get my films checked and I'll be back in about 5 minutes. Okay? If my patient is on a stretcher, I'm gonna make sure that I put both of the side rails up, whether the caretaker's in there or not. Okay? So this is a mobile x-ray. I love mobile x-rays. I love mobile ultrasound. Why? I love to figure things out. The more complex the room, the better I like it. I like to be able to move the machinery around so that way I can get up and so I can do my exam. Not only that, I make friends up on the other floors. Okay, it gives me a chance to meet more people than in my department. Okay? Mobile x-ray is where we take the machine to the patient and we do the exam that is ordered.
Is it very difficult to move it, and is it like
Nowadays, oh no, that, you just push a button and it goes zzz.
More release.
Oh, it's bullshit.
Where before, you had to hold it up and then you had to push with all your might. You're gonna come across some dinosaurs. Okay? Pediatric patients, they always require special attention. You want to use a reassuring tone. Avoid treating a toddler like a baby. I would never treat a 5-year-old like I would a 2-year-old. I'm not gonna treat a 2-year-old like I would a baby. Okay? I'm gonna smile, I'm gonna use my eye contact, and I'm gonna be very confident in what I'm doing. Because not only that, I'm gonna say, we're gonna take an x-ray, and I'm gonna turn on this light, and if I have a toddler, I'm gonna let them put the light on. So that way they know that when I put that light on, nothing's going to happen. Okay? I'm gonna let them touch anything that they want to touch. Okay? I'm not gonna take a 12-year-old and tell them to say cheese. But I would for a 3 to a 5-year-old. Okay? You're gonna see all kinds of stuff. Okay? Straight face, you have no emotions. That doesn't mean that you can't finish your exam and go to the bathroom and cry. Done that a million times. Okay? Because you're gonna come across things that happen, especially to our young children. Okay? Now, we're gonna automatically assume who hit this baby. Okay? We can't assume that the baby's been hit. Okay, so don't treat the parents like they hit the baby. See what I'm saying? We are not allowed to have any type of an emotion. Okay? This is what you're gonna see when you go up on portals. Okay? The picture on the top left, that's the way that they are at the NICU. Okay, these are babies that are born premature usually. Okay? But just because they're born premature, sometimes those babies are so sick that they are in the hospital for several months, sometimes even over a year. Okay? This, you can see that they are having blood and it comes from the neck. So you're gonna have to put a plate underneath that baby. So you've got to be very, very careful about the tubes that are coming out and the tubes that are coming in. Okay? The picture on the left, that is called gastroschisis. That's where the baby is born and the intestines are outside the body.
The left or the right?
It's usually gonna, top right. Okay? That is where the baby is born and the intestines are born outside the body. Okay? You're gonna see that when you go up to NICU. And the baby here on the bottom right is just a little bitty preemie baby. Like my niece, when she was born, she was 1 pound 9 ounces. She fit in a little Emesis basin. Now, my brother, because his wife never knew she was pregnant, and that does happen. She never knew she was pregnant until she delivered a baby. And she delivered the baby at 27 weeks. Okay, it was 1 pound 9 ounces. So my brother and my sister-in-law decided to put a DNR on her. A DNR is do not resuscitate. Okay? Now, did the NICU, if they would have treated my brother and his wife any different than they would on a mother taking care of this baby, then they would have probably never come to the hospital to see the baby. Because they wouldn't have wanted to deal with the employees. Okay? But they didn't. They went every day to the hospital to see Rihanna. Okay? And Rihanna now is 33 years old. Yeah, she's a little bit slow, but she's got a job, she drives. Only because she had that human touch. She had that human, I love you, that, you know, my brother and his wife went every single day. And the baby lived. Now, they also gave the doctors to try some experimental drugs on the baby, because the baby was DNR. If the baby died, the baby died. But in return, then they were able to say, if your baby dies, can we put it on a respirator and you can donate the organs? And my little brother said yes. If the
Even of-
baby gets to the point where you have to put her on a respirator and she dies, then yes, we can harvest her organs.
Ma'am, even of a premature baby whose organs are not so developed,
I'm sorry?
even of a premature baby, ma'am, the organs were not so developed.
The organs?
Yeah, because the baby was very
They
premature.
can still harvest. The heart is good, the kidneys are good.
I see that some organs have
Yeah.
developed.
Yeah. The eyes are good.
Mm.
Well, with Rihanna, they weren't. They had to use vitamin E in her body
To help her eyes?
to help her eyes. That was an experimental thing.
Yeah. There are other premature babies that could take that stuff, so if they needed it, then they would have it.
Okay. So they had to make the choice. If the baby was DNR, are they willing to harvest her organs for other babies that needed it? You know, and how much will they be willing to do to save that baby? Any of these babies, the parents are going to have to make a decision. The least one of all of this is the gastroschisis. That is the least. So what they do is they encircle the intestines with a bag. They hook it up to the incubator, and then they let gravity let the intestines go back into the abdomen. And so that way they can do surgery on it. Adolescents, they're very aware of their body, so you make sure that you ask for permission, because a lot of them are very modest. They don't like to change clothes with you. They don't want to change clothes for the examination, but if they do, make sure they're in a dressing room. Okay? Make sure they're in a dressing room. I would never bring a patient into the room where they have to get completely undressed and I have them in a room. I'm gonna take them to a dressing room. What time is this class over? 11:45? What time is it?
11:23.
Oh, we're almost done. You don't need a break. Okay. Again, always ask permission to touch, and never be afraid to have a chaperone. Okay? Ask another student, ask the technologist to stay in the room with you. Okay? Always keep track of that. Geriatrics, okay? A lot of these will feel alienated, and we can make that worse by showing them a lack of respect. Okay. For instance, this weekend, I went to spend the night with my mom. She's 88. She loves to cook breakfast. She asked me what she wanted, and I said, whatever you feel like cooking, Mom. I never offer to cook breakfast, because that's her thing. So after breakfast, I gathered up our plates, and I took them to the sink, and I started getting the yolk off of the plates. She goes, I told you not to do the dishes. I said, Mom, I'm not doing the dishes. I'm just trying to get the yolk off of the plate so it won't be so hard. Let me do what I can do when I can do it. And I said, yes, ma'am. In other words, she thought that I was showing her a lack of respect because she had already asked me not to do the dishes. But I thought I was doing good because I was just trying to get the yolk off the fork and the plate so it won't be so hard to wash later. And then she screamed at me because she's already getting to the point where her body is not letting her do what her mind has always let her do before. She's slowing down, and she's having a hard time with that. Okay? So when you talk to your patients, try not to raise your voice too much because they might not be hard of hearing, and that is a sign of disrespect. And don't treat them like a child. Okay? Be sure you use yes sir and no ma'am.
Even these days?
Oh, especially for the elderly.
Yeah, didn't move.
Yeah, especially for the elderly. Your generation, I'm not gonna say he or she. But for people my mother's age, oh yeah, you can bet I'm gonna say yes ma'am and no ma'am.
Okay.
Okay? Because they're like me. I don't understand the pronoun stuff. That doesn't make any sense to me. Okay, the aging process, you've got primary and you've got secondary. Primary is gradual, it's inevitable, it's going to happen, and it begins at childhood and extends into old age. Secondary is because of disease, abuse, or disuse. Name me one disease that would cause my geriatrics so much problems. Like,
Dementia, Alzheimer's.
yeah, dementia, Alzheimer's, diabetes. Okay, because if I have diabetes, I don't have good circulation. Lymphadenoma. Lymphadenoma is where my legs swell. Okay. Patient
Osteoporosis.
lose.
or
Osteoporosis,
Arthritis.
arthritis. My mother, kyphosis. Don't know what kyphosis is. Kyphosis is hunchback. Scoliosis is a crooked spine. Okay. Like for instance, my mother can't hardly even get something out of her microwave right now. Because the microwave is at this level on me. Okay? So my mother's kyphotic, so she has to go like this and bend her knees just to be able to get something out of the microwave. You think that makes her irritated? Absolutely. Okay, absolutely. Now, is that primary or secondary?
Secondary because.
It's secondary because she has kyphosis. Okay? Interacting with the terminally ill. Terminally ill patients go through what they call the Rubler-Ross sequence of events. Denial and isolation are gonna be the initial reactions, and then anger comes about, and then bargaining. God, if you'll heal me from this, I'll go to church every Sunday. Okay? Following the bargaining, you have depression.
Ma'am, the symptoms you said are the Kubler-Ross.
Yeah. It's a cycle that we go through. Everybody goes through it. You don't skip a spot. Okay? Same thing goes with a death of a loved one. Yes.
You said that everyone goes through it, but people go through it at different rates, right? Like,
Yes, they all go through it at different stages. Okay? And all we can do for them talk to them, listen to them, and guide them into the next direction. Okay? Denial, you're in avoidance, confusion, elation, shock, and fear. Anger, they're frustrated, they're irritated, they're anxious. Bargaining, struggling to find meaning, reaching out to others, telling one's story. Depression, overwhelmed, helplessness, hostility, and flight. Acceptance, you're exploring your options, you're making a plan, and you're moving on. Okay? Preparatory depression comes from the realization of the inevitability of death, accompanied by a desire for death as a release from the suffering. Okay? When my dad was diagnosed with renal cell carcinoma, when he broke his arm, he was putting in a light switch, and the electric screwdriver popped his arm. When it hit the end, it broke his arm. He immediately, the next day, decided that he wasn't going to eat or drink anything. He was going to die. Took him 38 days.
He
Okay?
didn't eat all those things.
Never took a sip of water, didn't eat anything for 38 more days, and he died. Why?
And you couldn't.
Because he could no longer work. He could no longer, it was his right arm. He couldn't feed himself. So my dad decided, this is what I'm going to do. I'm not going to put my family through any more. When he got put down and he had to go into the bed, that's where he went, and that's where he stayed until he died. Okay? So he did 2 of these at one time. He did the preparatory depression because he was already upset that he had renal cell carcinoma, and he knew that they couldn't do anything for him. He was already a stage 4. But when he broke his humerus, he went into acceptance. He had his plan all taken care of. Was it hard on the family? Yes, it was. Because we wanted him to eat. We wanted him to drink. He was still talking to us. But he just wanted hospice to come in, make him comfortable, and let him die. And that's what the family did. Okay? There's 3 types of communication: aggressive, assertive, or passive. Aggressive, I care about myself, I don't care about you. Assertive, I care about myself and I care about you. Passive, I don't care about myself, but I do care about you. Okay, that's the types of communication. Oh, that's the end. Any questions? Okay, so on